Good morning, everyone. I am Lee Briscoe-Dwyer, and I'm pleased to do the intro for today's Lunch with a Leader, where Ruth Cassidy is going to talk about high reliability organizations and what that means from an excellence and quality standpoint. We're very lucky to have this expert talking with us today. As we all know, Dr. Cassidy earned her Bachelor of Pharmacy degree from St. John's University, a Doctor of Pharmacy degree from the University of Florida, a fellowship with the American College of Healthcare Executives, and her Master's in Business Administration from West Texas A&M University. She is currently the Senior Vice President of Clinical Support Services and the Chief Pharmacy Officer at SBH Health Systems in the Bronx, and associate faculty at the CUNY School of Medicine. So I am going to turn it over to Ruth. She does have a very impressive introductory bio, but I think that what you have to offer us today is, we can talk about that later.
All right, thank you. And good afternoon, everyone. Thank you for joining. So we're going to kick off with some of the learning objectives. Let me see, I want to make sure I'm working this correctly. All right. So the way I'm going to work this is in the beginning half of this presentation, I'm going to give you some background research on high reliability organizations. And then I'm going to go into an implementation of how we did it at SBH Health System and specifically within the Department of Pharmacy. So first for you, I'm going to define what a high reliability organization is, or HRO. You're going to hear me say. I'll talk about the origin of an HRO. We're going to look at the framework of an HRO and what are the foundational pillars that you'll find that are instrumental in building this type of a program. I'll talk about the significance of an HRO in the healthcare industry. We're going to look at strategy. So what can we do to achieve HRO status? And then finally, implementation. So you're going to see it in the Department of Pharmacy specifically, and how we drive excellence down to the department level. All right, to start you off with some famous quotes. One is from Aristotle. Obviously, quality is not an act, right? It's a habit. And John Ruskin, quality is never an accident. It is always the result of very intelligent efforts. So on the number of many people, certainly it's multidisciplinary. All right, so in 2010, the Institute of Medicine attempted to estimate the amount of waste in the US healthcare spending, right? And they proposed 6 areas where there was a real source for waste. And so first is a failure of care delivery. And that's when there's practice or system-based inefficiencies. 2, a failure of care coordination. And this is when we're talking about unnecessary ED visits, unnecessary readmissions, or avoidable complications. 3 is overtreatment or low value of care. And you're talking about overtesting or overdiagnosis. 4 would be pricing failure. And here we're talking about a variability in pricing. So specifically medications would be appropriate for us. Also medical devices and tests. 5, fraud and abuse, which hopefully we never have, but there is a cost associated with that, and it's significant. And then administrative complexity. And so this is really related around billing and coding, and then any physician administrative burden. So if you look at the journal of the Agency for the JAMA, so it's the Journal for American Medical Association, and they had a special communication in 2019, and what they talked about was waste in US healthcare systems, and they specifically estimated the costs and the potential for savings. So there were 3 authors at the time that did this, and it was Schenk, Rodstadt, and Perrock. And what they concluded was that based on those 6 domains that we just talked about, the estimated cost of waste in the US healthcare system ranged from $760 billion to $935 billion. And so that was about 25% of the total healthcare spending. And that was 2019. If you went back to 2010, we were actually worse. So there had been some improvement, but we really didn't make significant improvement. So what is an HRO, or a high reliability organization? Well, the Institute of Health Improvement, and there's a lot of definitions, define this as an organization where safe and effective processes can be executed over sustained long periods of time. So the concept of high reliability, you would ask, why is it attractive in the healthcare industry? Well, it's really due to the complexity of our operations and the risk of significant and sometimes almost catastrophic consequences when failures occur in healthcare. So you'll see often that high reliability is mistakenly interpreted as standardization. And when you talk about an HRO, it's not just about standardization, although that's good. I think an HRO and the foundations of HRO go far beyond just standardization. So let's look at the pillars. And these are characteristics of high reliability, and we'll just take a look at each one. So first is a preoccupation with failure. And so HROs view any inconsistency as a symptom of a problem within a system, and it leads to early error detection and prompt interventions. So what are we talking about here? So this is where everyone is thinking about the potential for failure. People understand that new threats can emerge in this highly complex environment. And so everyone is at a real situation awareness. Everyone is actively thinking about, how can the system fail? So a good example for us under this pillar would be near misses for medications, right? We look at near misses as opportunities, right, to learn where we had failures in our systems, and there's a potential for improvement, rather than looking at it as just, wow, we got, we did good here, right? We didn't get as far as the patient. So this is where we really want to turn around and take a look at what actually did go wrong, and could we, because we don't want somebody else to fall into that. The second pillar is resistance to simplification. And so here you take deliberate steps to understand the work environment, and you value diversity of opinions and expertise. So people in HROs understand that work is complex and it's constantly dynamic. So a good example here would be COVID, right? We, on a daily basis, we were changing processes, right? All new guidance was coming out. We were constantly changing, and you had to bring in all the experts to say, okay, what's our next move? How are we going to do this without having any errors? And so they recognize although they're recognizing, again, the value of standardization, the workflows are variable. And so they appreciate that complexity, and they really all band together to make a change. Next is the sensitivity to operations. So HROs here monitor systems for safety and control to ensure that safety checks remain in place on a daily basis. And that's at the micro level. If you look at it on a macro level, you're saying, based on the understanding of the operational complexity, people in HROs strive to maintain a high awareness of operational conditions. So you might think of this as, again, situation awareness, that they look at what's going on around them, and they monitor all of their systems and all of their processes on an ongoing basis to make sure that nothing is going to fail. The next pillar is a deference to expertise. So in this situation, there's no resistance to defer to the entity or the person, right, that has the most expertise to solve the problem, especially in a crisis situation. So for me, senior vice president, I can walk onto a floor and people get very nervous, or they assume that I'm just going to kind of take over the operations. But I could walk into radiology, which is one of my departments. I'm not the expert there, right? I'm the expert in pharmacy. So in radiology, I want them to speak up. I want them to tell me what is the next best thing. So people in HROs, again, appreciate that the people that are closest to the work are the ones that are the most knowledgeable. And that means that people that are in a higher level aren't necessarily the people with the most expertise in that area. So HRO, everyone is expected to share concerns, and they need to have a level of comfort to be able to share those concerns. Next and final, pillar is the commitment to resilience. And this is where HROs develop a capacity to detect, contain, and recover from errors. So here, again, this commitment to resilience is rooted in a foundation, an understanding that frequently unpredictable nature of failures, it's going to happen, right? We're going to find an error. We're going to break down. And so you want to be able to recover from that. So the teams promote situation assessments and close monitoring so that they can identify these potential threats early on and find an avenue for success. Okay, so let's talk about where this came from. So the HRO theory actually originated with what's called the normal accident theory. So that's kind of counterintuitive, don't you think, a normal accident? So the initial work actually focused on nuclear aircraft carriers, air traffic control, and nuclear plants. And here, in the industry of nuclear plants and obviously the operations are incredibly complex. The characteristics of the operations are highly interactive as well. So the odd term of normal accident is meant to signal that given the system characteristics of being highly complex and highly diverse, multiple and unexpected interactions of failures are inevitable. And when you look, this is a book by Perot, and when you actually read the book, he goes into just a day in the life of a person where everything goes wrong. And so in the book, they ask the question, did one of those items actually cause the entire thing to cascade? Was it everything, or was it actually nothing? So it's an interesting concept. And if you have an opportunity, take that opportunity to read it. But this work is what expanded to other high risk environments, and healthcare became one of the largest focus of this ideology. All right, so we're going to take a leap now into healthcare, right? Because we know that this ideology is incredibly important in healthcare. So there are a lot of, you can go out there, Joint Commission has a lot of information, IHI has a lot of information on high reliability. This quote actually comes from Health Catalyst, and it says the necessary pieces for developing and sustaining a culture and system that delivers safe, high reliable care and strong, effective leadership, a culture of safety, and an accessible learning system. So let's look at what I want to tell you here is, all right, so if you're going to address quality improvement skills, there were two experts in the field. One was Alan Frankel, the other was Michael Leonard, and they created this practical, systematic framework that you could pretty much apply to almost every healthcare system. And so we're going to take a look at that. So this framework looks at one, leadership, right? So leadership, what I always say, well, you've heard the expression, fish rot from the top, right? So leadership is very important, and the leadership has to drive that safety of culture. But within the safety of culture, you have a lot of components, such as we talked about psychological safety. We want to make sure people feel free to speak up. We also want to make sure there's open communication among the team. And you have negotiation. You're always going to have people that are going to really feel that their point of view or their perspective is the most important. And so you have to look at that. But what's most important in this entire framework is this learning system, right? This active learning. And we see learning, and you might have systems online or competencies that you do on an annual basis. This type of learning is done on a daily basis, which needs full transparency. It needs constant measurement. You have to really have measurements of success. And when you're talking about the engagement of patients and their families, you have to have trust. And to get trust, you need reliability, right? When patients come in, they're in their most vulnerable states. And so they are trusting you. And to take care of them. So in order for that to happen, you want to ensure that you have reliable processes, that everything that you have is not going to fail for this individual person. So HRLs excel because of the leadership. The leadership really takes charge of that safety of culture and promoting a culture of safety and embedding continuous learning improvements into the system. That's the idea. They took this one step further and they broke it down. It's the same framework. They just broke it down to clinical and operational excellence. And they defined each one of those avenues that you had seen previously. So in develop this, again, still the same two individuals that developed this, but let's take a look at each one. We talked about leadership, right? It has to start at the top. You have to have your executive leadership must be involved. Also at the department level, you need your directors involved, the nursing directors, each individual department. For psychological safety, again, people have to be free to speak up. They're at the front line. If you step on as a senior vice president, because you are going around this institution, when you walk onto the floor, you want to make sure that your staff feels free to speak up with any issues that they're currently having and that they're empowered to speak up. Accountability. When you look at accountability, you have to look at systems. So in this accountability, you're going to look at just culture, right? So you're not going to say, okay, start pointing fingers. It was the nurse who did that. It was the doctor who really, fell on this time. It was the pharmacist who forgot to verify. What you're going to do is take more of a just culture approach, and you're really going to look at the systems, and hopefully it's the systems that have broken down, because in most instances it has, right? Well, we've had many of these examples. One was, Chris Cherry, right? That's the biggest one that everybody talks about, where the pharmacist was actually jailed. And another one most recently was the Vanderbilt nursing incident, where the nurse is actually indicted because she had given the wrong medication. But if you went back to both of those instances, you could really see that it wasn't necessarily the person. They didn't wake up in the morning and say, you know what, I want to go inside my job today and try to really harm someone. The systems failed them. And honestly, it could have been anybody. It just happened to be them that walked into it. So it's really unfair to point fingers at any particular system person. You have to really take a step back and look at the systems. The others we talked about, but the learning system, I just want to stress here again that it's a continual, on a daily basis, very measurable on a daily basis. And so this concept honestly takes a lot of work. Okay. So that's the high level, right? And so I hope you stuck with me, because now we'll talk about SBH Health System's HRO journey and how we did it. So this is the detail that we had gone into, and this is the specifics of how we moved into a high reliable organization. I want you to keep in mind that an HRO is a journey, right? This is not a destination. You're never going to say, I've made it. I need an award. This is a constant vigilance to continually strive for excellence and quality. All right, so what can I tell you about my hospital? So SBH is a community-based, patient-friendly healthcare system serving individuals and families in the South Bronx. The SBH, or St. Barnabas Hospital, is a 422-bed, not-for-profit, non-sectarian acute care community hospital, and it is a level 2 trauma center. And the majority of our ambulatory care visits, we are a major provider. There's about 400,000 outpatients. Some of you have very large organizations. We are one acute care facility, so this is a large number for us. And also, we are one of the largest providers of mental health services in the Bronx. We also have a lot of residents. We have about 280 medical residents that cross almost every discipline. We also have nursing residents, and we also have pharmacy residents. So the Joint Commission, when we look at our journey, what the Joint Commission suggested was that hospitals and healthcare organizations work to create a strong foundation before they actually begin to mature to a high reliable organization. And there's a lot of fundamental elements that actually have to go into this process. So when we started our journey, we're going back 10 years at least, when we really started to say, okay, we want to move into this, and what do we need to do to build this foundation? So first, we started with these couple of things that are listed on this slide. So daily safety call. Every day at 8:45, and it only lasts 15 minutes, every single department gets on the safety call, including the CEO, CMO, and the COO of the hospital, and they listen to the problems that occurred overnight. Every department reports out if they had an issue and what that issue was. And that's been going on now for at least 10 years. Patient Safety Friday. So when Joint Commission is coming, we do this on a weekly basis. If we're not in the window for Joint Commission, we do it consistently every other week. And what happens on Patient Safety Friday is, for 1 hour, we have a presentation from a department. Pharmacy reports twice, but every department will report out and have a presentation for about a half hour. And then we walk around the institution, and we see, just like at Joint Commission surveyors, and see what are wrong. Anything that's jotted down is about 4 people that go out, and there's 4 teams that go out. So at least 4 different areas are observed every Friday or every other Friday. Anything that they find related to the Joint Commission standards is reported back, and those departments have to then fix those issues and report back how those issues were fixed. Just Culture. I talked about this a little bit before. We had a huge rollout of Just Culture to make sure that people were comfortable. We really wanted them to speak up about med errors. We didn't want them to feel inhibited. We wanted them to report, because the whole idea was that we could take those errors that were occurring, or near misses that were occurring, and really start to look at our systems. We had a lot of committees with zero harm, surgical site infections, pressure ulcers, everything. We were shooting for zero harm, and we did achieve. We were certified for a few different areas in surgery for actual zero errors or zero harm. So we had no surgical site infections, which was great. So we were doing all this. We had our foundation in place, but the thing that was really missing was that, and we also had a learning organization. Don't get me wrong, most of us do, right? We feel we're training all the time. We teach our pharmacists all the time. We teach most of our disciplines. We have either an online course, we do competencies, we do presentations all the time, but you don't hit everyone. So what we really wanted to create was a sustainable, reliable improvement system. And in order to get there, we needed to make sure that we had the frontline staff involved. So what we introduced was lean daily management. And lean daily management is a disciplined daily process of gathering data and assessing performance metrics. The process drives appropriate behaviors and countermeasures that create a culture of seeing and solving the organization's key problems. And the goal is to turn our organization into focused problem solvers and continuously improve. So we started lean daily management in 2017. So we've been doing it now almost six years. So what happens here is every day there's 4 teams, and the senior leaders have their own team, and the senior leaders go to 20. We started out with just a few, right? We started out with 3 or 4, but now there's 20 departments that are involved, pharmacy being one of them, where the senior leaders go to each of those departments. It lasts about 1 hour, and so let me just get to this. It lasts about an hour, and what happens is every single department has 4 metrics that they have to follow. One is under better health, which has to do with safety. One is under better care, which is about the patient experience, and it could be age caps or something related to patient experience. The third is least waste, which talks about cost and productivity. And the last is more joy. So this is all related to the quadruple aim, right? We want to make sure that people are happy. So what makes them happy? And the team really has to think about, because this is at the front line. So it's not, the senior leaders don't come and say, okay, pharmacy, here's what your metrics are going to be. it's actually the opposite. It comes from the front line up. So it's the front line that says, okay, what's important to us? What is important to us as far as better care and safety? What's important to us as far as making us happy? And they pick their metrics, but the metrics have to be real, and they have to be able to measure each of those metrics on a daily basis. So they get approved because they have to show that they can actually do this metric every day. So when does LDM occur? Every single day, and it has for the last 6 years. It occurs from 9 to 10 a.m. Now, I will say that during COVID, we couldn't walk around the hospital, right? So what they did was they made this online. And so what happened was this entire process, they actually, each department had an iPad, it's hooked up, they're able to see it, and we can get in through Teams or Zoom. We have Teams, not to talk about any particular one, but we can get on and they can see us as senior leaders, and we can see each of the frontline staff. Remember, senior leaders also have a board. We have 4 metrics. And so when we walk onto the floors, first we talk about what our metrics are, and we measure our metrics on a daily basis, and we talk about what happened with our metrics. Then the staff in each of those departments go through their metrics and what they measured overnight, and was they successful? Had they been successful or not? And so eventually you start to see a trend. And as they start to move into, and let's talk about metric selection before I get ahead of myself. So again, what's important to the department? It has to be rapid cycle. Can the staff it has to be direct impact, right? So they can't say, okay, I want to talk about something nursing's doing from pharmacy. It has to be something that they can directly impact a change on. So it has to be something that pharmacy is directly involved in. And can I collect it on a daily basis is critically important. Red versus green. So red is actually okay, and people get a little nervous. This is a culture shift and a different way of thinking. Can you get red and be okay? So yeah, you actually can, and we tell them that, right? This is about improvement. So this is our way of identifying opportunities, right, for continuous improvement. The exception on red is on the safety metric, right? Once that goes to red, you immediately need to start to problem solve and get that into the green as soon as possible, because that could be impacting patient care. But all green, you don't want, right? You don't want to come in every day and everything is green, because then you've reached your goal, or you are doing it very well. So let's look at something else. Let's look at something that we can really improve. So if we're seeing all green, maybe it's time to change the metric. Maybe, again, we looked at the wrong thing and we need to, or we set our goal too low. So here, if you remember the framework, the learning system now eventually becomes redesigned. So that under that learning system, you saw problem solving, you saw transparency, you saw reliability, improvement, measurement. This is what happens during this Gemba walk. With these metrics, it's a constant learning. It's a constant measuring of how they're doing with their metrics. So you're creating a standard problem solving methodology, and it leads you to true cause measurements, right? So the result is really a data-driven approach to improved and sustained business performance. The daily metric shows that you're missing or you're getting to your goal. You have a Pareto chart, which identifies the most common trend. You really have to get to the why. Why did it happen? So if something went wrong, when we're going around as senior leaders, we say, well, why did that happen? And when they answer, we ask, well, why? We just keep asking. So they have to answer why 5 times so they really understand what went wrong. And then you identify actions to take, or just a small test to change to trial. So I wanted to show you, if we move into pharmacy, I wanted to show you what our board looks like. And this is actually in every department. So if you go around to the 20 different departments, this is the type of board you're going to see. And here you can see pharmacy has a metric under each better care, better health, least waste, and more joy. And when they come around, the entire department comes. Obviously, we keep operations going, but the majority of people will come to this board to meet the senior leaders, and they will, as the senior leaders tell them about their metric, they then in turn turn around and tell them how they met. So you can see under better care, they're starting to turn green. Some of them, they're actually doing well. And when you've sustained that green for a long time, then you can change your metric because you probably are doing okay. And if you find down the road that you started to fall out, you can always turn around and relook at it if you need to. But for the most part, you would hope that once you start to sustain that green and consistency, that you can actually begin to move to another metric. And all right, so like I said, pharmacy has been doing this for about 6 years. We've had a lot of metrics. So I wanted to just pick a few. What I also want to tell you is that with these metrics, because you're measuring them on a daily basis, you look at operational items and you also look at some clinical items. So for our metrics, we try to have 2 that are related to the pharmacists, and we try to have 2 that are related to whatever the techs do, because we want to make sure that the technicians are also involved in this continuous learning. And when they report out, it's the pharmacist who will report out on the pharmacy items and the technician will report out. So it makes them very cognizant of what's happening. They make sure that they stay on top of those metrics because they have to speak to it. And they're speaking to senior vice presidents and then sometimes the executive vice president, because the CEO will sometimes come around. So this is one. We try to, in pharmacy, we always look at some operational. We also look at some clinical. So just to give you an example, what I did here was I gave 2 examples, one in operations, and this happened to be operations. So this happened to be IV workflow system. And so when we were implementing without mentioning any names, when we started to look at our IV workflow, we wanted it. Sometimes there's resistance, right? So with this particular one, obviously it's going to slow our pharmacists down, right? They said, why do I need an IV workflow system? I'm faster on my own. I don't need this. But what we found was there were definitely inconsistencies in how pharmacists were preparing those products. Everybody kind of worked just a little bit different. So with this, again, we could standardize what was happening. We could make sure that we minimize the variation in different ways that certain individuals worked as opposed to others. And so it took some time. Also, what was good about this is when you start to show these, so you start at the Gemba walk and you're talking to the senior leaders. So an IV workflow system or any system that you implement in pharmacy on an operational basis costs money, right? So with something like this, you can actually now show your administration and your executive vice presidents how this actually worked, right? Did their money go to a good cause? You can show them, one, that you implemented, how quickly you implemented it, where you got to, and how it impacted patient care. And that's always a good thing. So this particular one, what we actually did was we took it and presented our executive copy because they did spend a lot of money on that workflow. And we wanted to show them just what I said, exactly how quickly it was implemented, how well it was implemented, how effective it is, and how it impacted patient care. So when we started out, and it was back in 2019, you can see the number of preparations that were going through it. We started out with 67. When we started to monitor this through our lean daily management process, we were having a hard time getting pharmacists to really be engaged. So they started to look at it themselves, and they started to drive the success from the ground up, from the front line. So they were looking at it saying, okay, we're at 67% because what? Why? Right? Here's your 5 whys. Well, that particular drug wasn't built in the system. We didn't have it. So they kept bringing back to the managers why that system wasn't working effectively. And we would make the changes so that it worked for them at the front line. And so gradually over a year, we were able to get up to 100%. So it was a great job. They still are at 100%. Once in a while, you'll have a new drug that comes in, and then we'll get that implemented. But this was a great job at the front line. This is more of a clinical one. So we had opened 2 outpatient pharmacies. One was in 2021, and then we opened the second in 2022 in August, actually. So not too long ago, not just last year, the end of last year. Those 2 pharmacies were very successful. But what the clinical team, and we have somebody who does specifically meds to beds. We have both the pharmacist that focuses on transitions of care, and we have a technician that works with them. That's we call an apple position, and they are a liaison between what happens between the pharmacy and making sure that patient has the medications that they need when they go home. And our goal was to make sure that every patient that walked out of the institution had those meds in their hand. So this looked at right from the beginning of 2021, when we first opened the outpatient pharmacy. We had been doing meds to beds before that. You can see where we were. We were using contracted pharmacies outside of the institution. You could say that we were, how many we were doing. It was very low in 2020. And once we opened our own pharmacy, we could really drive our success. We could really ensure that those medications were in the hands of the patients, and we made sure that they got there. And so you can see over just 2021, the curve went significantly up, and the meds to beds deliveries went significantly up, as well as the revenue. So this not only was it presented to QAPI, we also did a poster presentation. We have various poster presentations throughout the institution. And this particular one was one that we could present to the administration. Was very happy with this. When the second pharmacy opened, we've gone even higher, not only with meds to beds, but we're also looking at prescriptions that come from the clinics. So another point I wanted to bring up related to pharmacy is the senior leaders I mentioned also have their board, and they, as they do their Gemba walk, they're talking to the various departments. 2 of the metrics on the senior leader board are specifically related to pharmacy, and one of them is meds to beds, and the other is the outpatient clinics for the specialty pharmacy. And so the senior leaders are looking on a daily basis what's happening in those 2 pharmacies, both from meds to beds. We also have our own insurance, so they look at what's happening with the staff prescriptions who are under that insurance. And then they look at the specialty pharmacy to see what are the clinics doing. Are we losing some of our patients or our revenue to other pharmacies that unnecessarily, and we can actually speak to some of the clinics to say, hey, what's happening here? Why aren't you, what are your concerns, and why don't you want to use the pharmacy? So again, HRO, as I said, is a journey, right? This is an example of what happens in pharmacy. We do this, as I said, in several other departments. We have a total of 20. Some of my other departments, radiology, lab, all of them are working on their own 4 metrics. And it's been incredibly successful for the institution. These are certain things I think that anyone can take back, right? You can take this back to your organization. It is easy to implement. The concern is you have to have engagement. So if you have the engagement at a senior leader and executive level, this is very easy to bring home. All right. And with that, I went through that a little quick, I think, but with that, I'll take any questions that anyone may have.
So if anybody has any questions, you can certainly just, because I think it would be difficult to try to see the entire screen, you can either throw something in the chat, or if there's silence, you can go ahead and start by introducing yourself so that Ruth knows who she's speaking to. But Ruth, thank you. This was so good. It was so enlightening. And I think that it speaks to how with, between COVID and the growth of specialty pharmacy and meds to beds, pharmacy has really been able to get a seat at the table because now everybody is talking about it.
100%.
And we went from cost of doing business, we have to have pharmacy, we have to have pharmacists, to now, where's my pharmacy? How can you help?
So you're absolutely right, Lee. Yeah. I mean, I would say second to maybe the OR, really depending on how large your institution is, pharmacy is a #1 budget. So you are 100% correct. You absolutely can drive some of the success in your institution. And I can tell you that those 2 pharmacies, I was given a hard time to open them, but once they opened, they were like, well, we should have done this earlier. Yep. So they were so happy with the success I presented to the Board of Trustees because they were shocked with how successful it was. So pharmacy is driving the bus for revenue generation. It's not just a cost center anymore. So you're 100% correct with that. Mm-hmm.
So, and it's great that I'm going to say that you've been able to kind of step in and take advantage of that and make sure that, pharmacy has that spotlight, if you will, and being able to lead your success in pharmacy through other areas. And I think that that's, again, something that, none of us really ever learned in pharmacy school, right? That, you are not limited by the walls of the pharmacy.
That's right. You couldn't have said it better. And I think pharmacists underestimate themselves. Honestly, there's so much more you can do. You don't really even understand how intelligent, how you can take everything that you do in pharmacy and apply it to almost every other department, because pharmacy is so self-driven. Most of the time you're managing your own budget, you're managing your own purchasing. Other departments don't do that. And so you can really take that knowledge and take it to many other departments. And it really is nice to see pharmacists move up in the organization, because you certainly can.
We do have a question in the chat, and I think it's geared toward everyone, but certainly I think Ruth can start. It says, do you do all pharmacy, all prescriptions, or only specialty prescriptions at your outpatient pharmacy?
So we have 2 outpatient pharmacies. The first one that opened was just a general community-based practice pharmacy. And so we do everything. So all meds to beds. We take patients off the street if we needed to. It's a full pharmacy. The specialty is obviously linked to specialty, but in that pharmacy, it's actually on the first floor of the clinic building. And so all of the clinic people that are coming, as they walk out the door, they can get their prescription filled there, and they have their prescriptions in their hands, so they don't have to go anywhere else. Again, sometimes it takes convincing. Even doctors, they're like, well, why should I use you? Or the patient, why should I use you as opposed to my neighborhood CVS? So you have a great opportunity to say, we look at your entire picture, right? Mm-hmm. We have your entire healthcare record, and we are the best one to take care of you because we're looking at you as a whole. And so we have clinical pharmacists that work related to specialty and the outpatient pharmacy that can reach out to patients. Patients can call them to have a real conversation about the things that they're worried about with their medications.
And I as a great, move to the next question. Brooke asked, do you find that patient adherence is improved with meds to beds? And how do you document that? And how do you make sure that your clinicians, your providers actually understand that?
So what we actually did was we looked at readmissions. And so it takes a little bit of doing, because sometimes the systems aren't all so easily linked, but we could show that the patients that we gave meds to beds to did not come back. And that's how you drive success with your physicians, because physicians want to see that their patients are actually, 1, taking the meds, and 2, that they are doing better. So yes, 100%. We've shown that. And I keep saying to my clinical staff, you guys need to publish this, because it's pretty incredible to see how we have driven unnecessary readmissions, which is great.
Yep. And, and don't ever think that your project is too small to
right.
publish and to share, right? So
that's right.
Put an abstract together and submit it to the state council, and show it at the annual assembly, and then you'll get some growth and you'll get some momentum there. So everything that you do is going to be interesting to somebody else.
So in specifically in the ED, right? So the emergency room, most of the time they don't get their prescriptions. So we work specifically, we have a pharmacist, a clinical pharmacist that works in the ED, and he drove this meds to beds program in the ED. The doctors and the nurses were just thrilled because every single patient had the medication, and it was a huge success. Even the medical director of the ED actually reported, and I said, "Hey, you're stealing my thunder. You can't take my work and present it as, right?" But it was, they're so happy with how successful it was that they presented it themselves.
Yeah.
So it was great.
Another question for you. Did you use a pharmacy management service to build your specialty pharmacy, or did you grow it from the ground up?
I grew it from the ground up. And here's the reason why. So we're a 150-year-old institution. We're 340B. We do not have extra money. I actually interviewed all of those companies that will help you with specialty. And I said, why? Also, when it came to opening the pharmacies, so I will say I owned 3 pharmacies in the past, so I kind of knew how to do this. And I had a great team behind me. But it just irked me to no end to have somebody taking 25, 50% of my revenue. I just said, I'm sorry, I just can't do it. I can't, so yeah, it's a little harder, I will tell you, but some of these consultants, honestly, they don't know as much as you do, and you wind up doing the work yourself anyway. So if you're going to do the work yourself anyway, you might as well just do it. So we did it ourselves.
Yeah. I mean, if you're going to use an accelerator, again, I would just say, read that contract really, really carefully, make it as short as humanly possible, and make sure that you have a way to get out, because, to your point, Ruth, eventually you're doing all the work yourself.
You are.
So,
and, and they've made, some of the consultants have made errors in some of the recommendations, and we will call them out on it. So it's just, honestly, most of the work you can do pretty well yourself. You're smarter than you think.
Another question, if you know off the top of your head, what % of inpatient discharges get their prescriptions from your in-house retail pharmacy?
So we look at that actually every single day. And right now, we're only at 25%. Because I just presented it to the Board of Trustees. We have 37,000 prescriptions that leave our hospital or our clinics, and we only get 25% of that. If I increase that number by just a small percentage, the amount of revenue to this institution is drastic. That's what, when I presented that to the Board of Trustees and to the CEO, that's when they started to adopt the metrics on the senior leader board, because they said, okay, we need to move that needle just, a small percentage more.
Yep.
So we have a lot of growth.
Yep. And, and with the closure of so many large chain pharmacies, it's the perfect time.
That's right.
So, you take advantage, it's like literally, I mean, it sounds a little strange, but you drive around your neighborhood and you find out that the CVS that was across the street isn't open anymore. Or, you get a phone call from the mayor of a little small town that's down the road that says, our Walgreens is closing, at the end of March. How can you help me?
Right.
So,
and quite honestly, Lee, we can do it better. And that's not to say anything about the community-based practice pharmacies or the CVS pharmacists, because they're all pharmacists, but they are inundated with production. And so they can't take a step back to do the clinical aspect. So in an inpatient pharmacy, you have your clinical team, right? You can rely on them. You can say, hey, you can call up your ICU person and say, I have a person who has a question about opioids. I'm really inundated right now with filling prescriptions. Can you speak to this person? And they do. So you have a larger team to really help you. And that's very advantageous. Yes,
agreed. There was a question. Will this recorded webinar be available to members? I'm going to assume that it's yes, because I can't imagine why we would have recorded it otherwise.
I believe it was recorded. It says recorded, so yes.
Yep.
Yes.
So I will make sure that we circle back with the council office to make sure that everybody knows how to actually access that. So yes, Helen, your answer is yes.
Any other questions, Lee?
I don't see any more. Oh, wait, got one more. Hold on.
Yeah, please don't be shy. We talked about that.
Oh yeah, Angela said it will be available on the the NYSCHP YouTube channel.
Oh, awesome.
Thank you, Angela.
Awesome. Yeah, that's awesome. Thank you.
Obviously, look, it takes a village, right? It took three of us to try to get this thing going. And
that's right. That's right.
So
I appreciate and Lee, thank you so much for being a moderator. I tremendously appreciated you being able to jump on.
My pleasure. I was happy to do that. We do have another question. Do you feel that 25% can be increased through the opening of more outpatient and specialty facilities?
So we just opened the one in August, so it's not that long ago. That pharmacy went from zero, right? These are brand new pharmacies, went to zero. They're currently doing 300 scripts a day. They're only in the first 4 months of them opening. They already beat their projections. They already superseded their revenue projections for the entire year, because they were supposed to open up earlier. It was delayed a little bit because of construction, so they banged it out of the park. We have a lot of room to grow there. I would say it depends. You have to, obviously, and we do it every day, right? We monitor what's happening. If that particular pharmacy is overwhelmed and you're just beyond capacity. So when I did the first one, we had 400 square feet. I begged for space. I was like, guys, you have no idea how much money I'm going to make, and they didn't believe me. They were like, oh, we'll give you 400 square feet. It was barely enough to open a pharmacy. So we outgrew that pharmacy within 6 months. In 6 months, I said that we would turn a profit. We actually turned a profit in 4 months. By a year, I had made like $10 million. So I said to them, I can't physically work in the space anymore. You have to give me another location. And that's when they gave me the space in the clinic. So you can, like I said, pharmacy can drive the bus at this point.
Yep. And this example that Ruth just gave, it is not unique. All right. It's been, it's the same type of success that I had. Almost anybody that you're talking to that actually does, go out into the outpatient world, you will be very successful, because
yes,
again, when you're not focusing on the front end, the only thing that you're focusing on is your pharmacy.
Right.
And so you have greater capacity. And, you will, again, we outgrew some space. We're moving into another space. And literally, when we went to our board and we presented, they said, is this going to be enough space, or do you need us to find you more? Because we don't want to have to do this again. And I figured, no, at this point, we're probably good, because now now that we've got space, we can expand hours and, kind of there's different ways to grow. But it's just been so incredibly helpful for patient care, for the organization, and for pharmacy.
Right.
It's
well,
really...
and your community. Listen, you increase your footprint in the community. People look to the hospital. They look to pharmacy specifically because you are helping them, right? We can do brown bagging in the pharmacy. We can do so many different things for the community. So you really become in front line with the community, which is awesome. They love our pharmacists, which is great. So it's a great opportunity. If you can take that opportunity, please do. You'll be successful. I promise you.
All right. Let me make sure I've got.
They were all great questions, by the way. Thank you so much for the questions.
But thank you, Ruth, again for your time to be able to present today. I think that this Lunch with a Leader program has been extremely successful. So make sure that you're getting it on your calendar, that you're sharing it with your staff, you're sharing it with your residents, because people would pay big money for this.
You're right. You're right. All right. We could have done a whole presentation on outpatient pharmacy.
There you go. I think we might have to take this on the road, Ruth. I don't know. Maybe.
So thank you all very much. I really appreciate your time more than I thank you, because I know that there's no CE credits or anything, and you took time away from your day. So I greatly appreciate it. Thank you so much.
Thank you, everybody.